Facebook is live? Okay. Once you see it on Facebook, let me know, and then we'll start the video. You're live? Okay, I'm rolling video.
Good evening and welcome to the virtual Hot Topic Mentor Session, which is being shown live on the Alamo Breast Cancer Foundation Facebook page and also on the Alamo Breast Cancer Foundation website. I am Rosanna Ellis, the moderator for this evening. So first, I would like to thank our sponsors for making our programs possible. And they are Agendia, American Association of Cancer Research, AACR, the Joe W. and Dorothy Dorset Brown Foundation, Eisai, Exact Science, Genetic Bio-Oncology, Merck, Novartis Oncology, Pfizer, Sanofi, Genzyme, Seattle Genetics, San Antonio Breast Cancer Symposium, and Viatris. As we always have done, tonight we will begin our sessions with each mentor providing an overview of a specific topic or session. And please be sure to post your comments and questions during the talks, and they will all be answered after all the mentors have spoken. So before I introduce our mentors for this evening, I would like to thank them for giving so generously of their time and knowledge. We truly appreciate them, as well as our viewers, for their interest in expanding our knowledge of breast cancer and for their continued support of the Alamo Breast Cancer Foundation and our advocate programming at the San Antonio Breast Cancer Symposium. So I'm very pleased to introduce you to four of our incredible mentors this evening. Dr. Bitsy Ademuyiwa, she kindly allowed me to call her Dr. Bitsy, as she is known by her patients and colleagues. Dr. Julie Gralow, Dr. Suzanne Fuqua, and Dr. Virginia Kaklamani. So For the first time, actually, welcome Dr. Bitsy. She's the breast medical oncologist and associate professor at George University School of Medicine in St. Louis, Missouri. Her research interest includes breast cancer clinical trials, triple-negative cancer, early onset breast cancer, and racial disparities in breast cancer research. Then Dr. Fuqua is a professor of medicine and molecular and cellular biology at Baylor College of Medicine in Houston, Texas. The main focus of her research is to determine the role of a specific somatic mutations in estrogen receptor alpha called K303R and Y537N in the clinical problems of hormone resistance. Dr. Julie Gralow is a professor of breast medical oncology and professor of global health at the University of Washington Washington School of Medicine, a member of the Clinical Research Division of the Fred Hudson Cancer Research Center, and the director of the Breast Medical Oncology at the Seattle Cancer Care Alliances. Her clinical expertise includes investigational breast cancer treatments, chemotherapy, hormonal therapy, biologically targeted interventions, and her research focuses on preventing the spread of breast cancer to the bone. I'd also like to point out that Dr. Gralow was recently named the next Chief Medical Officer of ASCO and will begin her new position in February 2021. And last but clearly not least, Dr. Virginia Kaklamani is a professor of medicine in the Division of Hematology and Oncology at the UT Health San Antonio and is the leader of the breast cancer program at UT Health San Antonio MD Anderson Cancer Center. Her research interests include studying high-risk families and identifying genetic mutations that are associated with an increased risk of breast, colon, and prostate cancer. So very accomplished panel for tonight. And I would like to invite our first mentor to talk, and they will pass on each other. I think Dr. Bitsy will be our first one.
Okay, thank you for having me. Thank you for having me. So my name is Bitsy Ademuyiwa, and I'm very pleased to be here. I'm going to be talking about the ASCENT trial. This was a trial that had been presented earlier this year, actually at the ESMO meeting. And today they presented some biomarker analysis from that study. So I'm going to briefly summarize what was presented at ESMO and then talk about the biomarker analysis that was presented today at San Antonio. So ASCENT was a large phase 3 international study investigating a medication called sacituzumab govitecan or Trodelvy for triple-negative breast cancer patients who have already received 2 different chemotherapies for their breast cancers. And so what they did was that they randomized patients. So some patients got the agent, the sacituzumab, I'll call it SG from now on, and the other group of patients got what they call treatment of physician's choice. So one of 4 chemotherapies that the medical oncologist could pick for the patient. And then they treated those 2 arms and then compared which drug was the winner. And so they found that patients who received the SG lived much longer than those patients who received regular chemotherapy that was picked by their doctors, which was very nice. And so recently, actually, the FDA has approved sacituzumab govitecan for use in patients with a triple-negative breast cancer. So today they looked at some biomarkers to see if there were any factors that could predict who would respond higher and who would get more benefit from the sacituzumab. And so before I talk about that, I wanted to talk about what the medication actually is. So sacituzumab govitecan is what we call an antibody drug conjugate, and that's more or less a newer kind of medication. We call it a targeted therapy. And so what it is that in the molecule, there is an antibody that is bound to the chemotherapy. And the idea is that the antibody goes directly into the cancer cell and then releases the chemotherapy into the cancer cell, so killing the cancer cell. And that's how antibody drug conjugates typically work. And so the antibody would look for something on the breast cancer cell called TROP2, and if the antibody sees that TROP2, then it will be targeted towards that cancer cell. And so in triple negative breast cancer patients, about 9 out of 10 of them will have this TROP2 on their cancer cells, suggesting that they will benefit from the SG medication. And so this biomarker analysis was really to look to see if patients with TROP2 levels, either high, intermediate, or low, would benefit in a different way from the medication. And so they took all those patients, many of the patients on the clinical trial, and they looked at their tumors and assigned TROP2 levels based on the expression and how the staining was. And so they classified patients into a low TROP2 group, a middle TROP2 group, or a high TROP2 group, again, based on the intensity of the TROP2 expression on the cancer. And then what they found was that patients who had a moderate or high TROP2 expression had the highest efficacy from the sacituzumab, although all patients still benefited from the medication. They also looked at BRCA positive patients, so patients with either a BRCA1 or BRCA2 mutation, to see if those patients that had the genetic mutation would have a higher benefit from sacituzumab. And what they found in that analysis was that really all patients benefited from sacituzumab versus the regular chemotherapy, irrespective of whether they had a BRCA2 mutation or not. And so in summary, basically the top line results from this analysis show that sacituzumab govitecan helps triple negative breast cancer patients live much longer versus either one of the 4 chemotherapy choices that were in the trial. And so this is now a very good option for breast cancer patients, triple negative breast cancer patients who have received 1 or 2 different lines of chemotherapy. And then BRCA patients, so either BRCA wild type or patients who have a BRCA1 or 2 mutation, all benefit equally from the medication. So this should not exclude some patients from getting the treatment or not. And then patients with TROP2 levels, moderate or high, seem to benefit more. But however, even those patients who had a lower expression of TROP2 levels still seem to get some benefit from the sacituzumab. So really, all triple negative breast cancer patients should be allowed to get this agent after receiving some medications and treatments for their breast cancer. Thank you.
I lost her video. I lost her voice.
Oh, I'm still here.
Still okay. I'm so sorry.
I can hear you.
Well, okay, fantastic. Thank you very much. Next, I'd like to hear from Dr. Suzanne Fuqua.
All right. Well, good evening, everyone. It's unfortunate that this is not on site because I always enjoy the lively, very lively sometimes, discussions by the advocates. So thank you for having me again this year. I'm actually going to talk about 2 talks that were in an educational session on Tuesday about metastasis. And the concept I'm going to dig into is minimal residual disease or disseminated tumor cells. So what is disseminated tumor cells? What we think is that they become dormant, and this dormancy has really been the target for a few years to try to understand the basis for it so that we could either keep the tumor cells that have left the primary site dormant and not doing anything, or to actually kill them. And they happen, we think, because when the tumor cells move from the primary site to distant sites, they do have a new microenvironment, and that can be harsh for the tumor cells to adapt to and learn how to live at that site. So that's one reason we think. And the other reason, and I think that the talks today that I'm going to discuss really hit on this, is that the therapy, intervening therapy while those cells are disseminating, plays a big role. So the whole concept is important because by killing these dormant tumor cells, we really might be able to block recurrence before it happens. Okay. So the first talk was by Andrea Bild at the City of Hope. She did a study using what we call single cell RNA-seq. So that's getting down to the individual cells in a tumor biopsy and finding out what are the genes that are being expressed. And she did this in the neoadjuvant setting. So this is before the primary surgery. The study was called Feline. And it was of high interest to me because the study is of high risk ER-positive breast cancer. Patients received endocrine therapy plus either a low dose CDK4/6 inhibitor or an intermittent high dose, which really I think gave additional information, which I was pleased to see that too. So I'm going to kind of cut to the chase and then tell you the details. Why I loved Andrea Bild's talk is that over the past year and a half, several groups now have reported transcriptional profiling of metastatic breast cancer. First, the genomic data came out, the mutations. We know that ESR1 mutations are one of the highest, probably the highest mechanism of resistance. And then mostly at San Antonio is where it's been presented. It has not been published yet. Last year was the different transcriptomes sequences that were overexpressed in metastatic breast cancer. And this study in 45 patients really did highlight some of the things we knew a year ago. So that was one of the first, I think, take-home messages, is that in this neoadjuvant study, and I'll tell you the details in a minute, she identified early on the transcriptional changes that were defined in metastatic breast cancer. Okay, so it was a big message to me that things are happening a lot earlier in the face of treatment, and it's not just a slow evolution. So the details. In an adjuvant study, they had a resistant and a sensitive population. Let's focus on the resistant population. So in the combo arm where you're treated with endocrine therapy plus a combination therapy, what happens is you start losing estrogen receptor expression, and that is compensated by two things. First, CDK4/6, which is a target of the CDK4/6 inhibitors, of course, is amplified. And what that does is normally ER regulates the cell cycle. If you start losing ER, you're upregulating the cell cycle. So now you're having estrogen independent activation of the cell cycle. The second thing that happens that she found with RNA-seq was that the receptor tyrosine kinases get activated. And that is another source of estrogen independent activation receptor, which is a common mechanism of therapy resistance that we know both in primary breast cancer and now, as we see of the data last year, also in metastatic breast cancer. And so, again, the take-home message is that using the neoadjuvant setting and very, very sensitive methods of detection, we can detect resistance mechanisms that we know happen in metastatic breast cancer. And then also because the trial was with both a low dose and a high dose intermittent, she was able to get finally down with her data in the bioinformatics. And I have to say she had a great bioinformatics team working on this, is that it appeared that the emergence of resistance early on in the neoadjuvant setting was less in patients who received low dose CDK4/6 inhibitors. So the take home to this, and then I'll add on the second one very briefly here next, is that many of the agents we now are applying in the metastatic setting are being used earlier. And I think that the mechanisms of these using these drugs earlier have a plus and a minus. I think those mechanisms are early and not just later. But I think we have to know what we're going to do with those resistance mechanisms if they develop. The second talk was a really nice talk from Lou Chodush at the University of Pennsylvania. And he has for a number of years studied mouse models. And you say, what about mouse models? So what he has been able to do is very exquisitely turn on or off an oncogene. And when you turn it on, you get a tumor in a mouse. You turn it off, the tumor can regress or just sit there. But if you wait, with time, metastases happen. So he's been doing blood draws and looking at disseminated tumor cells during this process, and has defined a number of mechanisms with these oncogene mouse studies that he thinks defines the dormant tumor cell. And that's really been a great achievement, and I think that many people are additionally working on. So two of the mechanisms is something called autophagy. Okay, it's a mechanism of cell death. And the other was mTOR. And we do have an agent for mTOR called everolimus. And then hydroxychloroquine, I know we've heard a lot about that during COVID, is an agent that facilitates autophagy. So what he did is his main goal was to provide something for women in the post-adjuvant setting. Sorry about that. It's been a long day. So he has been working with a clinical trial called CLEVER, where they monitor disseminated tumor cells, and that's done with a blood draw, post-adjuvant treatment. So as you know, there's a great need for something for surveillance after women finish 5 years or 10 years of endocrine therapy, like for ER-positive breast cancer. So the study is underway, and so we don't have the results yet. But he did mention that I think that he's working towards a very important method for surveillance that's less invasive. So the current assay for disseminated tumor cells or dormant tumor cells is quite laborious. You may get one cell to make your diagnosis on. It does predict recurrence, but it's just not really a clinically amenable assay. So he is working on a flow-based assay to define the disseminated or residual tumor cells. And the data look quite nice. In fact, in his study, the surveillance study they did prior to the CLEVER study, 30% of women, high-risk breast cancer women, had disseminated tumor cells as defined by this flow assay. So it is a bone marrow aspirate for surveillance during the post-adjuvant treatment period. But I do think that it's the next step to providing women with surveillance, as we all want after you finish hormonal therapy. So that was it from the metastasis basic biology area. Thank you.
Thank you very much. Very, very interesting. And now I would like to hear Dr. Gralow's overview.
Hi, everybody. And hi to you all over the world, wherever you may be. I'm so sorry that we're not all face-to-face, and I'm hoping to be able to see you all again next year. So thanks to the Alamo Breast Cancer Foundation for inviting me back again. I've picked two presentations from today's General Session 3 to highlight. The first is the SWOG S1007, or the RxPonder trial. And the second is the meta-analysis of pregnancy outcomes after a breast cancer diagnosis. So let's talk about the S1007 trial, the RxPonder trial. That was abstract number GS3 for General Session 300. It was a late-breaking abstract, so it doesn't have a real number on it. This was a study looking at using a genomic assay, the 21 gene recurrence score assay, in a population of early stage breast cancer patients that have estrogen receptor positive, HER2 negative breast cancer, and 1 to 3 positive lymph nodes. And looking to randomize these patients that have a low recurrence score, a recurrence score of 25 or less, to receive endocrine therapy alone or chemotherapy followed by endocrine therapy, and looking to see if we can safely withhold chemotherapy in this population. So let's give a bit of background on why was this trial done. Going way back in time to the year, somewhere around the year 2000, we had a bunch of trials that were looking at endocrine therapy with or without chemotherapy in early stage breast cancer. Some of the early chemotherapy trials that were done in non-metastatic breast cancer, and we were seeing that chemotherapy was adding. And we held a big consensus conference at the National Cancer Institute on the adjuvant therapy of breast cancer. And the conclusion was that virtually all early stage breast cancer patients should get chemotherapy because we can't figure out who doesn't benefit. Now, as soon as we made that statement, one, we knew it was just the wrong thing, and we needed to do a lot of work to figure out who didn't need the chemotherapy. And so groups started working on assays and trials that would look at, okay, who really will do just fine on endocrine therapy alone. And this 21 gene recurrence score assay was developed looking at a group that we thought most of the patients in this group could probably do pretty well with just endocrine therapy, and maybe only a subset of them really need the chemo. So using older trials of chemo with and without endocrine therapy, where we had tissue and we knew which patients had recurred and which patients hadn't, this 21 genes recurrence score assay was developed that picked out a group who did fine, they did very well without chemo, and then another group who seemed to benefit from chemo. And then this was tested in a prospective study called the Taylor X trial that was published a few years ago in lymph node negative patients with estrogen receptor positive, HER2 negative breast cancer. And it held up that if the recurrence score was high, 26 or greater, then there was a benefit to chemo. If the recurrence score was very low, there wasn't a benefit. And the Taylor X looked at that middle group, the group that had a recurrence score between 11 and 25, and it showed that adding chemotherapy didn't add very much in that group. Now remember, these were lymph node negative patients. Interestingly, what we saw was that when we used a cut point of the age of 50, that the women over 50 with a recurrence score in this intermediate zone really didn't benefit from chemo, but women under the age of 50, when you got closer, moving up to a recurrence score, 16, 20, getting closer to that 25 cut point, those younger women did seem to be showing some difference from the older women and were showing some benefit from chemotherapy at a lower score. So all of that is background behind what the S1007 or the RxPonder trial was. So this was a very similar design to the Taylor X trial, except for now we were focusing on, can we define a group of women who actually have 1 to 3 positive lymph nodes that also don't need chemotherapy? So we can exclude all of the long-term and short-term toxicities of chemo if they're not really benefiting. So the RxPonder trial used a cut point again of 25 or less and asked women with ER positive, HER2 negative, 1 to 3 lymph nodes, early stage breast cancer, if they would agree to be randomized to just getting endocrine therapy or having chemo added to the endocrine therapy. So this trial went on for quite a while. We accrued over 5,000 patients with many international sites participating. And it turns out that there's for all of these big trials, a data safety monitoring board who is carefully watching a very small group of people who are watching the data. They're not affiliated with the trial, and they're protecting the patients essentially, so that if they see trends going in the right direction or the wrong direction, if they see problems with toxicities, they have the right to close the trial early. So the Data Safety Monitoring Committee for this trial had their third interim analysis. They were very far from the point at which we were planning to report the data, and they said, we're seeing something here that's making us think that we really need to get this information out to the providers, to the patients, because there's some important information here. So they then went and talked to the National Cancer Institute, had a small group meeting, and decided that the results of this trial needed to be unveiled a bit early. And what they showed was two important things. One is that for the postmenopausal group, and we carefully, as we enrolled patients, asked about their menopausal status as they enrolled in the study. For the postmenopausal group, there was no hint of a benefit of chemotherapy if you had a recurrence score of 25 or less. That's who we entered in the study. Not a whiff of it. We looked at the lower recurrence scores, the more intermediate recurrence scores. So women over 50 who have recurrence scores that fall in the low to intermediate range, even though they have 1 to 3 lymph nodes that are already showing signs of cancer spread, they did not benefit from chemo. And we can safely conclude that the majority of those women do not need chemo. They do not need the side effects of chemo, and they are going to do very well without it, with just the endocrine therapy alone. Now, we saw a very different outcome in the women who identified themselves as being premenopausal when they entered the study, and that was about a third of the women on the study. For those women, when we looked at the effects of adding chemo or not, we saw a benefit even in the intermediate group and even in the low recurrence score group to adding chemo. So something about having the ovarian function at the time that they were diagnosed with breast cancer meant that they needed something more than just standard endocrine therapy, which at the time was predominantly tamoxifen. And so while the conclusion is that for women over 50, we now have really good evidence that even if they have 1 to 3 positive lymph nodes that have been involved with cancer, we can omit chemo. For women who are under 50, we need to think a little bit harder and maybe give chemo. And we also need to study whether it was really about the chemo itself, the chemo interaction with the cancer, or whether it was more a result of the fact that one of the main side effects of chemotherapy in young women is that it at least temporarily, if not permanently, shuts down your ovaries. And could we accomplish that, if that's really the major reason that we saw a difference in the study, by just giving a shot that shuts down your ovaries, as opposed to giving the chemo, which is much more toxic? So lots more work to do there to understand, was it really the chemo or was it the ovarian suppression that was going on in the younger patients? But starting tomorrow, we can feel very comfortable about omitting chemotherapy in a lot more patients with node-positive breast cancer. Now, a little shorter summary of one more abstract, which was abstract GS3, General Session 309, and that was a meta-analysis looking at pregnancy after a diagnosis of breast cancer. And they had 3 specific areas that they went back into the literature, looked back at all of the published trials that they wanted to address. What were the chances of pregnancy after a breast cancer diagnosis compared with both the general population that was age matched, as well as a population of patients with different kinds of cancers, not just breast cancer? So what was the chance of pregnancy? What were the reproductive outcomes? What were the complications? How did the fetus do? And then the third was the maternal safety in terms of recurrences and deaths associated with pregnancy. So number one, the chances of pregnancy shouldn't surprise you. Compared with the general population, women who had a prior diagnosis of breast cancer had a lower chance of pregnancy. And when we looked at women who had been treated for other kinds of cancers, cervical cancer was the only other kind of cancer that had a lower chance of getting pregnant compared to the general population than breast cancer did. As far as reproductive outcomes, there were no major differences in complications. There was a higher rate of C-section seen, and the babies that were born had a higher chance of having a bit lower birth weight or being born a bit earlier, preterm birth, or being small for their gestational age. There was no hint of any increase in congenital abnormalities, which is really great news. And when they looked at the subset of women who got chemo and then had a pregnancy, and those who had a breast cancer diagnosis but didn't get chemo and then had a pregnancy, almost all of those findings, the low birth weight, the preterm birth, were in the group that had gotten chemo. And then the last thing they looked at was the maternal safety. What did pregnancy negatively impact recurrences and death due to breast cancer? And no matter how they looked at it, they just did not see any detrimental factors related to recurrence or to survival. If anything, the data favored that the women who went through a pregnancy were doing a little better. And they even subset it by BRCA1 and 2 mutation carriers. Did they have a detrimental effect? Patients with lymph nodes that were positive. They looked at estrogen receptor positive versus estrogen receptor negative. Was there a different effect? How about patients who got chemo or not? And really, there were no detrimental features impacting recurrence or survival that were seen. And of course, we have the ongoing positive trial, prospective trial now, looking at women, young women with estrogen receptor positive breast cancer, who after some interval of at least 18 months of endocrine therapy, if they want to try to achieve a pregnancy, stop their endocrine therapy and then try to achieve a pregnancy and then go back on endocrine therapy after their pregnancy. And we're going to have really good prospective data from the positive trial about the ability to conceive and the outcomes of the mother and the baby in that population. So I think this provides very reassuring news for women who have gone through treatment for breast cancer and want to achieve a pregnancy, that there are no safety issues to either the baby or the mother that have been seen in this presentation. Thank you very much, and happy to take questions at the end.
Great overview. Thank you very much, Dr. Gralow. And Dr. Kaklamani will be our final speaker for this evening before we begin our question and answer portion of our program.
Well, like Suzanne said, this is always the highlight of the meeting for me. And so the fact that this is virtual kind of is a bummer. But next year, we'll all be vaccinated and ready to come on live. So I'm going to talk a little bit about immunotherapy. I'm going to talk about a new drug, and then two other studies I wasn't planning on discussing, but I think are important, especially for our advocacy audience. So two studies were presented today about immunotherapy. One was Keynote 355, which was a clinical trial looking at a medication called pembrolizumab. This medication was recently approved by the FDA in women with metastatic triple-negative breast cancer. And the reason for the approval was this clinical trial. So this trial looked at the combination of immunotherapy, pembrolizumab in this case, and chemotherapy, and it showed that women that received this combination compared to just receiving chemotherapy had an improvement in some of their outcomes. We're still waiting on this clinical trial to see whether the survival of our patients improved because of the addition of immunotherapy. But previous trials have demonstrated a survival benefit, so hopefully this one will as well. Another very important trial was the Impassion 031 trial. And this was in women with early stage breast cancer, where we gave a different immunotherapy medication called atezolizumab before surgery, so what we call in the neoadjuvant setting. And this trial was presented recently at another meeting in Europe, but the presentation today had to do with patient-reported outcomes. And again, very, very important aspect, because we're giving chemotherapy to these women. Now we're adding other medications like immunotherapy, and are we really compromising their well-being? And thankfully, the trial showed that the two arms of the trial, the arm of where women only received chemotherapy and the arm where women received chemotherapy and immunotherapy, did not have any differences in side effects as far as how women reported those side effects. So the quality of life of our patients decreased in both arms because they were getting chemotherapy. But after they finished the chemotherapy, it increased again. So that helps us be a little more confident in adding medications like immunotherapy to our patients' regimens, showing that studies have shown that they're effective, efficient, improve outcomes, but also at the same time do not cause more side effects. Another trial that was presented looked at a novel agent called an AKT inhibitor. And these agents had reported previous data on smaller trials, most of them presented at this meeting a year or two ago, showing that in triple-negative breast cancer, if you combine this AKT inhibitor to chemotherapy, you're improving patient outcomes. So this was a larger confirmatory trial trying to look at this AKT inhibitor in combination with chemotherapy in women with triple-negative advanced breast cancer. And we all were waiting for this trial because most of us thought that this would be the next drug to be approved in triple-negative breast cancer. And unfortunately, the trial did not show any improvement in outcomes. And this is, again, a lesson for all of us that unless we do large randomized clinical trials, we may not get the right answer as to whether a drug is effective or not. So very important for all of us to remember that these small trials are great. They're faster to do. They include fewer patients, and so they're easier to do. But at the same time, they may not give us the right results on how good a drug is. The last two trials I wanted to discuss are extremely important, and one of them looked at radiation toxicity and how patients graded their radiation toxicity results and physicians. And, you'd think that physicians would listen to patients and would grade radiation toxicity as well as patients do, but unfortunately they don't. And depending on what type of toxicity they were looking at, there was around a 30% difference in how the patients graded their results and whether they had pain, whether they had itching, and how physicians graded their results, meaning that we need to do a better job in listening to our patients when it comes to side effects from the treatments that we administer to them. Interestingly, two groups had an even bigger divide, and those were the younger patients and patients of ethnic minorities, such as Black, Hispanic patients. So those patients, the difference between what the patient was saying and what the physician was reporting was even higher. And this is important. This is, again, telling us that come Monday morning when we go to our clinic and talk to patients, we should probably pay a little more attention to what they're saying. And then the last one is an issue that we've discussed at the symposium many times in the past, the use of opioids, so narcotics, for women that are going through mastectomies. We know that the rate of mastectomies in the United States is increasing. We also know that the rate of contralateral prophylactic mastectomies is increasing quite a bit. That means if a woman's going to have a mastectomy, then for several reasons that we won't discuss today, she or the physician or both decide that it's a good idea to remove the other breast as well. And then, of course, they will have, in many cases, reconstruction. And all of these things are surgeries, and they're pretty big surgeries. Some of them, depending on the type of surgery, could be 5 or 6 hour surgeries. And at the end, women may have side effects, mostly pain. And what this trial showed was that women that were undergoing mastectomies, 13% of them were becoming new chronic opioid users. This means that 13% of the women that were having mastectomies started using narcotics, such as morphine, and used them chronically. And this is a major issue for our patients. This is a major issue for the healthcare community as well. Again, interestingly, the women that were more likely to have that increase in the use of opioids were the younger women, women that were on Medicaid, women with a diagnosis of breast cancer, and women that were receiving chemotherapy. So this is, again, an important aspect, especially for advocates, because you guys talk to patients, newly diagnosed patients with breast cancer, and it's especially important to warn them as to what these surgeries may cause down the road. So I'll finish with that, and again, happy to take questions.
Wow, thank you all for your presentations, extremely interesting. We'll now start with the questions that have been posted by our viewing audience. And the first question I have is for Dr. Bitsy. I'm curious if Dr. Bitsy sees a role for sacituzumab earlier in the triple negative breast cancer, and is it being studied earlier line?
Yeah, this is always the question. When a medication has shown some effectiveness and good results in the later stage setting, then of course we want to quickly bring it to the earlier stage setting to see if it will help early stage patients and perhaps even prevent patients from getting metastatic disease. So I do know there's several trials in early triple negative breast cancer patients in the neoadjuvant setting looking at sacituzumab, and there are actually also trials in the advanced setting combining sacituzumab with immunotherapy that has been approved, such as atezolizumab, to see if that can potentially enhance the activity and make things better for patients who are getting the immunotherapies in the advanced setting, and also make chemotherapy potentially better or potentially replace chemotherapy. So all those trials are currently ongoing or are being designed. Yes.
Very good, very good. Thank you. One more question here. The question is, I would like, it's more a comment than a question. I would be surprised if you didn't cover RX Ponder S1007, smile face. Interesting data from this interim analysis. Looking forward to the mature data. Questions have arisen regarding impact of chemo-induced menopause and premenopause cohort. Any comments?
So that would be the ovarian suppression piece. What we know is we did collect data on what kind of endocrine therapy was being given in this population. And in the group that did not receive chemotherapy, something about 15 to 16% of patients received ovarian suppression with either tamoxifen or an aromatase inhibitor. So the majority did not, and they probably just got tamoxifen. But somewhere around 16% did get ovarian function suppression along with their typical endocrine therapy. So we're going to be doing analyses of that group. It's only a small percentage of women, but that is definitely something that we plan to analyze. In the group that got chemotherapy, almost nobody also got ovarian function suppression, most likely because a lot of them were pushed into an early menopause due to the chemotherapy. So we will be evaluating that, and many of us think that a major reason that the chemo is showing effect is not because of the chemo per se, but because it's what it's doing to the ovaries. So a good question. I was going to add one thing to the sacituzumab govitecan, which is it's a very exciting drug, and you've heard about all the trials that are ongoing. But we also have some data that this TROP2, which is what the sacituzumab govitecan antibody binds to, it's found on estrogen receptor positive breast cancer. It's found on other kinds of cancer types. And so we do have some early trial data that it has activity in estrogen receptor positive metastatic breast cancer. We're looking at it in other cancer types as well. So this is going to be a very interesting drug in terms of who's going to actually be a candidate for it.
Very good. Thank you. Thank you. Very interesting. The next question is quite interesting. They say, do you think any of this data from trials like RX Ponder will extrapolate to men? And why aren't men included?
So I'm happy to let anyone else take a stab at it. There are men who have gotten tested with the 21 gene recurrence score assay because we know when we talk to Exact Sciences, which formerly Genomic Health, we know that there are men that are having their samples tested, and I just haven't seen a great analysis of what's going on with those men. But they are being tested out in the community. Why aren't they being included in the clinical trial? Well, especially when we're talking about endocrine therapies and some of them involve the ovarian function and all. It's kind of a different question in this specific case. In general, for a lot of therapies, I think whether you're male or female should not matter, and we would encourage broad enrollment. When we're looking specifically at endocrine therapy types of approaches where a woman's kind of endocrine makeup is very different from a man's, I think it would be hard to interpret anything from the small number of men that might accrue, if that makes some sense. In general, I'm very much in favor of being as inclusive as possible in clinical trials.
Very good. Any other question? Any other comments? Let's go to the next question. The next question would be, in the RX Founder trial, it's very popular, can you highlight any differences in the lobular breast cancer that might have emerged? Will there be any subset analysis or additional research to understand any differences? And lobular is thought to be less chemo responsive and higher rates of noble metastasis.
So I'm not sure if I got all the pieces to that question. The first was about lobular. I have not seen any analysis of if lobular looked different from ductal, but we do have tissue on all of these patients because we had to send it to do the genomic assay, and this certainly will be able to be knowable. Was there another part to the question that I missed?
Yeah, I think will there be any subset analysis or additional research to understand any differences?
Oh, you can believe that we will do lots of translational medicine and additional research and to try to sort it out. I mean, I think we feel really, really pretty comfortable about the withholding of chemo in the postmenopausal women, and none of us feel comfortable that all of these premenopausal women should be getting chemo. So we're going to be working very, very hard on sorting out, is there really a subset where the chemo itself and not just the ovarian suppression piece of the chemo really matters? And we're going to be doing a lot of work in that area, in different subsets, etc.
Yeah, great. You probably already, go ahead, I'm so sorry.
Oh, I was going to add that, I think that question is really a useful question because, when we see lobular histologies, most of them tend to be very rich in ER and PR, suggesting that they would, derive much more benefit from endocrine therapy rather than chemo. A lot of them are also very low grade. And so again, this question is very important because in clinical practice, we do believe that, many lobular carcinomas are not necessarily as chemosensitive than the more common ductal cancers.
Very good. Okay, so I'm going to go for the next question. What will the study look like to figure out whether it was ovarian suppression or chemo in the premenopause group with going over group with 1 and 2 nodes, or who will do it?
Well, if I thought of what if I thought of what the perfect study would be, but this would take some time, so I would hope that we could look at other studies in the shorter term. It would really be to take premenopausal women who have 1 to 3 positive lymph nodes and a recurrence score of 25 or less, and ask them if they would be randomized to ovarian suppression with endocrine therapy versus chemo with endocrine therapy. That would be the perfect trial, because if you didn't see a difference, you would have answered the question. But that kind of a trial, which I think should be done, does take quite a while to accrue the number of patients needed and then watch for recurrences. And hopefully both groups will do so well that there won't be many recurrences. So that means the trial takes even longer until you get the result. So it's a good thing when there aren't many recurrences, but it doesn't get you the answer sooner. So that would be the perfect trial. But we also have other trials looking at adding ovarian function suppression drugs that suppress the ovaries, like Lupron, Zoladex, etc., where we add those to chemo or not. We might be able to start teasing out some of those, because some of those studies patients also got chemo. So I think we're going to have to look really hard at what studies have already been done, where we know outcomes, where we have tissue, where some patients got ovarian suppression, others got chemo. And then we probably do have to plan a real trial where we head-on compare the two treatments.
Thank you. Very comprehensive answer. Okay, let's go to the next one. Is ADC and CDK4/6 inhibitor trilaciclib, and do you anticipate that we will see more crossover use of this drugs class in the future for this population? Anybody like to take it?
So I'm assuming the question is whether we can use a CDK4/6 inhibitor after having used a CDK4/6 inhibitor. And the answer is there are studies ongoing. We don't have the answer as to whether this is a useful strategy, but there are ongoing trials that will answer this question.
Thank you. This is more of a comment. Aside from I'm sorry. Please.
Yeah, I have a
Dr.
comment as well.
Yes.
Yeah. So there is accumulating mechanistic data that abemaciclib after ribociclib, there are different mechanisms of action. You might have better cell cycle blockage with abema. And then I think, I'm not a clinician, at least for a few reports, I think for San Antonio last year, of some patients responding to abemaciclib after ribociclib. So I do think molecularly there is support for following a CDK with another CDK inhibitor.
Oh, excellent. Anyone else? Thank you. Thank you. The next question I have, it's a lot of questions coming in the matter of time. You mentioned that MDs and patients differ in their perception about toxicities associated with radiation, and that these differences were bigger for younger and minority patients. Were there any MDs attributes, example, gender, age, academics versus community setting, that were revealed?
So interestingly, speaking of community or academic setting, there was a tiny little bit of a difference showing that patients treated in academic setting had a bigger discordance between what they were reporting, patient-reported outcomes versus physician-reported outcomes. The difference was very small. It was significant but small. So it's unclear whether this is true, and if it is, us academic physicians should be pretty worried, or whether it's really just a chance that we found that difference. Interestingly, when the trial was designed, the study was designed, they assumed that minority groups would have a bigger difference, and they confirmed that, which again is a signal that we need to take into account when individuals of Blacks, Hispanics, Asians report much bigger differences on their own perceived outcomes compared to the physician outcomes.
Excellent. Dr. Bitsy, anybody else?
Yeah, I actually thought it was very interesting that the speaker talked about, studies that had been done in medical students even people part of the healthcare community, and they believe that, blacks had different, pain mechanisms than other races. So they thought that blacks had different nerve endings and could feel pain in a different way and perhaps had thicker skin. So, these biases are really inherent in the medical community as well as other communities. And, things really ought to start changing.
Anybody else? Thank you. Thank you for your comments. The next one is for Dr. Gralow or any other speakers. Can you please comment on the most encouraging news released for MBC, metastatic breast cancer, patients this week so far, and the most important gaps that need to be addressed in the MBC research, in your opinion?
Wow. So I think we all probably have our ideas on this one. And we've actually had, for the last couple of days, some Twitter dialogue in advance about what we thought was exciting coming up at this meeting in metastatic breast cancer. I think we've had some, I think the major categories of metastatic breast cancer have kind of all been addressed. I think in triple negative, this kind of seeing the sacituzumab govitecan data and the biomarkers just really locks in. This is a drug that is really interesting and really works. I think the updated data on the immune checkpoint inhibitors that Dr. Kaklamani reviewed is really important, but I think we really have to sort out with pembrolizumab and atezolizumab, how do we do the assays that determine which metastatic triple negative are going to benefit? In the HER2 arena, we're seeing updated data on a lot of exciting drugs, but we've had a whole bunch of HER2 targeted agents approved just in the last year. We now have 7 FDA approved HER2 targeted drugs in the metastatic setting, and we're seeing updates on 3 or 4 of them at this meeting that are really telling us better how to use them. In the estrogen receptor positive setting, I think we're looking at the mechanisms of resistance that develop to kind of our classic endocrine agents. What are the best targeted pathways that we should be hitting at the same time as endocrine therapy? Are there some new pathways that we should be looking at? So I think, all of the categories of these have had updates and reports, but really a lot of it, in my opinion, is updates of things that we kind of already knew, but now it's solidifying it as we're starting to use these drugs. I don't know if my colleagues have other ideas. I know I'm just overwhelmed with the number of new drugs that are out there, but none of them were presented for the first time at this meeting that are really sticking out in my mind.
I would probably also add something that we all can do, and that was a study that was presented yesterday about the diabetic diet and how that can help improve our risk of recurrence. We all talk about these drugs. We all talk about immunotherapy that costs more than $10,000 per dose, and not to mention the toxicity to our patients. And sometimes we forget that the simple things can help. If a woman maintains a healthy weight, if a woman exercises, and the study yesterday showing that if a woman adheres to a diabetic diet, so diet low in carbohydrates, basically, she has an improved outcomes. So that's something that our patients can do without our help, and it's pretty cheap as well.
Very good. Dr. Bitsy I cannot hear her. Is she talking?
Hear me now?
Yeah, I can hear you now.
Okay. So there is a medication called trilaciclib, which is a CDK4/6 inhibitor. It's being evaluated as an adjunct to chemotherapy in triple-negative breast cancer patients, and there was very encouraging data It's an early phase trial, so phase 2 study showing improvements when you add on trilaciclib to chemo. But clearly, you know, as Dr. Kaklamani said, sometimes you can be fooled by early phase trials. So I know they've launched a larger phase 3 trial to see if the results will hold up. So that's quite encouraging. And then clearly the immunotherapy options for triple-negative breast cancer patients have been expanded. We have atezolizumab. We now have pembrolizumab, which you can actually combine with other chemotherapies, because there are some patients that are not necessarily ideal for nab-paclitaxel, which is what we typically give with Abraxane. But now with the Keynote study showing that pembrolizumab added to different chemotherapies can also work, it has sort of expanded options for triple-negative breast cancer patients.
A lot going on in MBC. Any more comments?
Well, I thought that.
Go ahead, please.
I was just thinking about an abstract that was in one of the poster sessions that I was very peripherally involved in, called the ITOmics study, which was, since the question was about metastatic disease. And I think that, so this was a study where about 30 triple negative metastatic breast cancer patients were enrolled, and serial biopsies were done kind of at baseline at the start of their metastatic disease, and then after various treatments. And genomics were performed, a whole bunch of different ways of looking at the DNA and the RNA and the proteins and all of that were done. And there are a couple of interesting pieces to that study. One, it showed it's feasible to do serial biopsies, and actually these tumors after each treatment were changing in various ways. And that's a really key take-home point, is that we need, if the tumor is now starting to grow through a therapy or it's acting differently, we need to look at it all over again, because there are changes happening. One really interesting thing that happened was 31 patients actually enrolled in the trial, and of 31 patients, 2 of them had all of their genomics, genetics, everything done, and they were actually reclassified as a lung primary cancer. So these were triple negative. They had recurred in the lung. A biopsy was done. Because their prior cancer had been triple negative, they just assumed it was triple negative breast cancer. But with a really in-depth look, they were actually called lung cancer, which is treated in a totally different way. So 2 out of those 31. I thought that was fascinating. And then they had tumor boards where they looked at all of these genomic findings and made recommendations. And out of the 29 patients, there were 38 different cases across all the patients where they were able to get access to drugs that were matched per the tumor board's recommendations based on the genomic findings, either through enrolling in a clinical trial or getting a single patient IND, which is something you can write for, or by getting off-label use approved of a drug that was already approved for another reason. And they have reported several patients with triple negative breast cancer who are on treatment, doing fine, more than 4 years out. Who knows if this kind of genomic targeted approach is what's attributing to them doing well for a long time or not. But I think this is where we're going in the future. And instead of getting biopsies in the liver or the lungs, it's easier if we can find it in the blood. So we're moving toward the liquid biopsies and trying to find these same kind of changes in the blood. And you can keep drawing the blood at much more regular intervals than you can sticking a needle in the liver. So that was a little study, but I think it drives home where I think we're going with metastatic breast cancer, is that we're going to understand the cancer in detail, the patient in detail, and then get the best treatments and then hopefully the best outcomes.
Learning a lot tonight. Thank you very much. So let me jump to the next question here. Given the results of the RX Ponder trial, is there any reason to order the Oncotype DX test for a premenopausal node-positive woman?
So that's a great question, because you might think that if we did not find a group that didn't benefit from chemo and we're going to recommend chemo to all premenopausal, 1 to 3 positive node patients, that why would we bother to order it? But here's what I would say. I would say, one, that the patients who have the very high recurrence scores are going to have really strong benefit from chemo. And that's the group that when I weigh the risks and benefits, I'm really going to push them, toward, you're going to get a lot more benefit than you're going to get harm. I would really encourage you to strongly consider chemo. For groups with a lower recurrence score, where I think we're all questioning how much of the benefit is really the chemo versus how much of it is the ovarian suppression, I'm going to have a kind of uncomfortable conversation for a while till we get more data, but I'm going to say, if we shut down your ovaries and we give you an aromatase inhibitor and maybe add on a bisphosphonate also to get a little extra bang for the buck, and we do that for 5 years or maybe 10 years, then maybe we're going to get the same kind of outcome. And would it really be worth all the toxicity? So I think it's a perfect question, because you'd really have to push me to say, do you really know that a lower recurrence score is, it's going to be okay to just shut down the ovaries? But I think it really helps me in my dialogue with the patient about how sure I am that chemo is really going to make a difference versus just offering ovarian suppression. Does that make sense? We have to talk a lot about things we don't have all the answers to.
We are looking for answers. Anybody else like any comment?
I'm interested to know what my colleagues think about that.
We don't know, and we're extrapolating, and there's different trials, and then you have the trials that have looked at ovarian suppression in the patients that received benefit. Most of them were patients that had also received chemotherapy before, but those are the patients where the chemotherapy did not block their ovaries enough to make them postmenopausal. So there's so many questions there that it really becomes a more fascinating and difficult discussion with the patient, like Julie just mentioned.
I do agree as well. I think there might still be some utility in getting these genomic testing in premenopausal patients, particularly if you think the biology is such that it would not really respond as strong to chemo. Maybe they're very strongly ER/PR positive, they have very low-grade tumors. I think it still might be worthwhile for a subset of patients to get this testing. And again, it will be a discussion with patients.
Agree. The next question is, could any of the speakers please comment on the DCIS poster session today, specifically the effect of the myofilial layer in the progression of DCIS to IDC? Anyone know this?
I was actually listening to the other poster discussion, so I missed that one.
Me too.
I missed that one as well.
So we're gonna skip that one then. I have another question. What therapy do you think will be tried next to prevent recurrence in the early stage high-risk hormone-positive breast cancer? And the follow-up question is longer endocrinology therapy and keep trying CDK4/6 inhibitor, something else? It's a long question. Let me do the first one. What therapy do you think would be tried next to prevent recurrence in the early stage high-risk hormone-positive breast cancer?
Can I go ahead
Suzanne.
and comment? Yeah, okay. Thank you. So I'm the basic scientist, the translational scientist, but I think that some of the data I saw today and I've seen in other meetings with some of the oral SERDs and some of the novel agents coming down the endocrine therapy pipeline, I think I'd love to hear what the clinicians think about using those earlier.
I mean, so far they've shown some good outcomes. There's phase 3 trials going on now with the oral surge in the metastatic setting. The hope is that those trials are positive, and then I would expect them to move into the adjuvant setting very, very soon. But remember, we just received data from the first positive trial, the Monarch E, with the CDK4/6 inhibitors in the adjuvant setting. So we're all pretty excited about that. We're waiting for longer follow-ups. We're waiting for other trials to present the report as well. But I'm assuming that that'll be the next drug to make it into the adjuvant setting.
Yep.
I think we're also waiting for. Oh, sorry. Go ahead.
Nope, you go.
We're also waiting for large adjuvant trials with PARP inhibitors in patients who have BRCA mutations to see if we would be adding those on in the adjuvant setting as a way to prevent metastatic disease in BRCA positive patients. So, those trials are coming as well.
I was just going to, add on what Suzanne had mentioned about the oral surge to make sure that all of the patient advocates listening understood what those were, because SERDs, which are selective estrogen receptor downregulators or degraders, the main drug we know of in that class, the only one we have approved, is called fulvestrant or Faslodex, and it's a really very good drug in the metastatic setting. We use it all the time, and it's got good, combination with CDK4/6 inhibitors, for example. But it's an intramuscular injection, and you have to give it once a month intramuscularly. And if we're talking about moving it into early stage breast cancer, I mean, can you imagine coming in once a month for an intramuscular shot for 5 years or 10 years? It's not practical. So fulvestrant, Faslodex, has not really moved into the early stage setting, not because it's not a good drug and not because we don't think it would have some potential for benefit there, but because it's just impractical. So these oral versions of this class of therapy, if they are successful, and there are many that are in phase 3 trials right now looking very promising, they will have the practicality and the feasibility to start testing them in early stage breast cancer. So that's kind of why we're excited about this potential. But I also think the CDK4/6 inhibitors, we're going to, we have a positive abemaciclib trial, 2 negative palbociclib trials, ribociclib under study, not yet reported. And I think we have to really look at, is it differences in the drugs, or is it differences in the patients? And, do they have higher risk patients in the abemaciclib trial? And what were the differences so that we can make sure that we're matching the best drugs to the patients?
Very good. Anybody else? Very good, very good. The next question is, I wasn't aware that mastectomy rates were going up. What's the cause of this, and what can advocates do to address this?
Mastectomy, especially contralateral prophylactic mastectomy rates, are going up, and this is multifactorial. It includes patients being very anxious about having a second breast cancer in the breast that is left behind. It includes physicians, especially surgeons, discussing the benefits of the cosmetic results of a reconstruction if both breasts are reconstructed. And ultimately, in the past few years, we've seen a pretty worrisome trends when it comes to patients having bilateral mastectomies. And what it has been clear from many studies is that the only individuals that benefit from having a contralateral prophylactic mastectomy, so mastectomy on the healthy breast, is some individuals with BRCA 1 or 2 mutations or other very, very high risk individuals that have had radiation to their chest wall. Everybody else does not benefit, at least they don't live longer, because they've had a contralateral prophylactic mastectomy. So this is a discussion that goes on in clinic, especially with the surgeons and the patients every single day. And this is something that we all need to get better at. It's understandable that women are scared, and it's understandable that this is a decision that's extremely heated. But at the same time, understanding also the potential side effects, long-term side effects that these surgeries are associated with.
Anybody else?
And I mean, I think also as reconstruction gets better and better, which is good, you see people mostly because of fear, tending to, try to get bilateral mastectomies because they know they can get reconstructed, which is good. So I think that plays some part into it as well. But I think it's probably mostly driven through fear is what I would say.
I would say, I think the question was, what can advocates do about this rising trend? I do think that it's a woman's choice as to the type of surgery and whether she removes the other breast, has a contralateral prophylactic mastectomy. I think it is our job, the healthcare providers, the advocacy community, to make sure that that decision is not made for the wrong reason, so that it's not made out of an unfounded fear, so that it's not made out of the mistaken belief that she will live longer. She'll have a better chance of surviving the breast cancer. So it's our job to educate, but, I also think it is the patient's choice, but we need to help her make an informed choice. And I've had patients who have said, I understand this doesn't impact the outcome from the cancer I have now. I understand that I will probably have more time for healing or a risk of surgical complications because I'm removing more tissue. But, I've already had 5 breast biopsies. I do not want any more biopsies. I do not want to go through another biopsy, the potential for more chemo, even if my survival will be the same. And so this is my choice. And when I hear it like that, where they absolutely understand what they're doing it for, then I would be I'm supportive. So we have to make sure that we're helping them not do it for the wrong reasons.
Informative decisions. Let me go to the next question then. How is the data for SG in ER positive trials coming? Does it seem like it will also work in ER disease?
I mean, I think so far, I haven't seen a full presentation yet, but my understanding is that there seems to be some efficacy. So I'm really looking forward to the results, and, potentially, again, it could be expanded to this group of patients as well.
Another comment? Another quick question about ER. When do you think we might see more trials with Pembro within the ER patients?
We
take this. Any takers?
Yeah, I think Virginia, you should take that one. You talked about the immune checkpoint inhibitors.
There are several studies looking at immunotherapy in this patient population. We always initially assumed that ER positive tumors are not immunogenic. So people are now looking at trying to make these tumors immunogenic, but there's also a subset of these tumors that is immunogenic. So this is definitely an ongoing field of investigation.
Okay, please, Dr. Fuqua.
Yeah, so there is preclinical research being done in the area. Our problem is there's not a lot of ER positive models, especially not in the mouse models, but now with some of the patient-derived xenografts. And I think there's some interesting data, but not published yet, that's coming out about the subsets that may express PD-L1. So stay tuned. Maybe next year we'll hear it.
And it's also actually, immunotherapy is also being evaluated in HER2 positive breast cancer patients. So there's a large trial adding on atezolizumab to chemotherapy with anti-HER2 treatments for patients who have HER2 positive breast cancer. So stay tuned for that as well.
Much more to come. Okay, so I'm doing time here. We have a few more questions we can cover. This was a question that was asked earlier and perhaps not well presented. With introduction of two new drugs classes, ADC, Trodelvy, and CDK4C, Trilasaclib, I'm sorry, I'm mispronouncing it, in clinical trials now, do you foresee more crossover of these classes in the triple negative breast cancer setting?
I'm not sure I understand the question, but the Trilasaclib data is still pretty early. So, we still have to wait for the phase 3 trial with that agent to show if the improvements in the phase 2 study will hold up in the phase 3 setting. With regards to the SG, sacituzumab govitecan, that has shown progression-free as well as survival benefits. So that agent is already it's already approved and available for triple-negative breast cancer patients, and it's being studied in the earlier phase setting. So I guess maybe the question is trying to ask if Trilasaclib is approved and we have sacituzumab, how are we going to sequence those agents? It kind of depends on what the magnitude of improvements is in the Trilasaclib study and in the what setting they looked at it in, whether first line, second line, or third line. For the sacituzumab, it's only approved once patients have received 2 separate different regimens. So, we'll just have to wait and see what the data shows.
So I think we covered most of the questions here. I'm just saying that give a few more minutes if there are any more questions coming in. I think we have covered all of them. Very interesting. I think that is a new format and people are getting used to the new format of sending questions and not being there. And we are all learning, and I really appreciate your patience. Let's see. Is there anything else that you'd like to comment or bring up in the sessions that have been presented today and yesterday that we haven't covered yet? I think we have covered a lot of material this evening. I really appreciate it. Well, I think that we are on time. We have a few more minutes. So I'm going to use this last minutes to really thank you all for the wonderful session. A special thanks to all our mentors, Dr. Bitsy, Dr. Gralow, Dr. Fuqua, Dr. Kaklamani. We are so grateful for your time and expertise, and we really enjoy hearing your thoughts on the day's events of the symposium. It's so enriching, and we all learn so much. We are really, really thankful for your continued supporting. And please join us tomorrow evening for our third and final Hot Topics Mentor session, where our speakers will be Dr. Steph Österreich, Dr. Debul Tripathi, and Dr. Matthew Ellis. And thank you very much, and we hope you enjoy the rest of your evening.
Thank you.
Thank you.
wine can prevent cancer, or does it cause cancer?
I don't think this video is about scolding those people that love and care and those people that have misstepped with their words.
Have you tried yoga? Yeah, I have.
I think this is really about the MBC community having a good laugh.
Have you swam in Lake Tiki?